All right. Welcome to the UNM Law and Mental Health series, weekly discussions of practice and science, featuring experts in behavioral health and the law. This series is run by the Division of Forensic Behavioral Sciences of UNM's Department of Psychiatry and Behavioral Sciences in support with the New Mexico Behavioral Health Services Division. I'm Kaisa Marshall, an assistant professor here at UNM, filling in for Anthony Perillo. For our talk today, please ask questions in the Q&A box anytime that you feel comfortable, but just know that we will not get to them till the end. We always try our best to get to as many of your questions as possible, but please forgive us if we cannot get to yours. If you are pursuing continuing medical education, the sign-in sheet will be in the chat shortly. If you are pursuing APA continuing education, the link will appear later, around the 50-minute mark. You have to save your certificate after you completed the survey because we don't keep copies. If you missed our most recent talk in the series, Dr. Tally Armstrong's discussion of a structured approach to addressing ethically questionable conduct by forensic colleagues is now available on our YouTube channel. The link for that channel will be posted in the chat box. The recording for this week's talk should also be available on our YouTube page later this week, and the PowerPoint slides will also be accessible for people registered for the series later this week as well. As a heads up for next week's talk in the series, we have Dr. Christina Dardis discussing technology-facilitated intimate partner violence. But let's get back to this week. I'd like to introduce you to today's speaker, who will be discussing the role and relevance of cognitive testing in forensic evaluations. This is Dr. Tatiana Matlasz. Dr. Tatiana Matlasz is a clinical forensic psychologist licensed here in New Mexico and in Ohio. She currently serves as the Associate Director of the Cuyahoga County Court of Common Pleas Court Psychiatric Clinic. Prior to that, she was here with us as an assistant professor at the University of New Mexico, where she completed a postdoctoral fellowship in forensic psychology and helped to build and formalize the Division of Forensic Behavioral Sciences, an effort which I got to see, and I know how instrumental she was to that. Dr. Matlasz conducts a variety of criminal and civil forensic evaluations through her current position and a private practice that she maintains on the side. She has presented on various topics like diagnosis, psychological testing, forensic and clinical assessment, and other forensic mental health topics to mental health, legal, and other audiences, both locally and nationally. She supervises pre- and postdoctoral psychology trainees and psychiatry fellows in forensics. She served on various boards and commissions and provided consultation to help enhance forensic mental health services delivery, including being a senior consultant for the SAMHSA Gaines Center. In addition, she has published peer-reviewed articles and book chapters on topics relevant to forensic mental health. So, Tatiana, Dr. Matlasz, it is a great honor to have you back here. We're excited to have you join us for our series and thankful for you to be sharing your expertise with us today. I'm going to turn it over to you now.
Thank you, Kaisa. All right, so like Dr. Marshall said, today I'll be presenting on the role of cognitive testing in forensic evaluations. So happy to be back and happy to be presenting on another topic that I really enjoy and could talk about for hours. So in efforts to try to keep it within 1 hour, we are just going to jump right in. All right, so this is the info on the CEs that Dr. Marshall just mentioned. This will also be in the chat. I don't have any conflicts of interest or financial arrangements to disclose, and the views that I express during this presentation are my own and should not be considered to represent UNM's views. Okay, so by the end of today's talk, it is my hope that you all will be able to describe the role and relevance of cognitive and intelligence testing in forensic evaluations, be able to list professional, ethical, and practical considerations involved in test selection, and then also discuss limitations to interpreting and applying test results to diagnoses like neurodevelopmental and neurocognitive disorders, specifically in the forensic context. All right, so the use of cognitive and intelligence testing in forensic evaluations is one of those topics that seems to come up really often. And this has been in discussions with attorneys, other mental health providers, and across all the jurisdictions I've worked in. It's also a really common topic in the literature. And I think there are a lot of reasons that this is such a popular conversation. So I'm going to go through some of these because I think it provides a good foundation or some good context for today's talk. So one of the reasons I think this is a hot topic is because there are varying levels of training and education surrounding psychological testing in general, but also the use of testing in forensic assessment. And this goes for mental health and legal professionals. Actually, most of the things on this list pertain to both mental health and legal professionals. So another reason I think this is a big topic of conversation is that there is a lack of understanding sometimes, or maybe appreciation for the differences between therapeutic or clinical assessment and forensic evaluations. So these two types of evaluations differ in a lot of key ways. So they differ in their scope, they differ in the voluntariness and autonomy of the examinee, how relevant or important the client's or examinee's perspective is, pace, setting, lots of things. But one of the really big differences that's relevant for today's talk is that, the goal of a clinical assessment is typically to provide a diagnosis or treatment recommendations, do an assessment that is going to help the client or help the examinee maybe to get services or treatment. Whereas in forensic assessment, the goal is very narrow in scope. So we usually are tasked with answering a very specific question for an attorney or the court or the trier of fact. And because forensic evaluations and clinical assessment differ so much, the data that we collect, including any testing data, really differs too. And the reasons why we may or may not conduct testing and how we might interpret test results also differ. We're really going to get into that today. Another reason that this topic is such a popular one, I think, is because we know there's a lot of variability in the types and number of tests that are used in forensic evaluations. So, for instance, there's one study that was done by Tess Neal and Tom Grisso, where they surveyed 434 experts internationally who identified a total of 286 different tools across their 868 cases. So, a lot of variability. And the findings that they got from their study are not unique to just that study. We see this across the literature. Next, a lot of misconceptions about what certain tests actually measure. What tests are for, what they mean, how much weight is appropriate to place on these tests. Again, we'll talk about this more later, especially when we get into test interpretation. There are also a lot of different professional and ethical dilemmas that crop up around psychological testing in forensic evaluations. So, for instance, what do you do when an attorney requests specific types of testing, or it's in the court order to do IQ testing? Or what do you do if they subpoena your raw test data? Other issues arise too from working in an adversarial system. So, some evaluators might feel a pull to conduct testing because they think it lends an air of objectivity or science to their report or their opinions. Or maybe they see that the opposing expert did a whole bunch of testing, so they feel like they need to do some testing to seem like their evaluation was just as comprehensive. But they might do so even if testing doesn't provide any incremental validity or any relevant information. So a lot of different reasons why this is a hot topic. So my goal today is to provide you all kind of a crash course in considerations surrounding the use of testing in forensic evaluations. We're going to talk mostly about cognitive and intelligence testing, but a lot of what we discuss is should generalize to other types of testing. All right, so like I said, several things to consider if, when, and how to use psychological testing in forensic evaluation. So how do we decide when to administer testing and what kinds of tests to administer? We can answer this by looking at best practices. So best practices are comprised of the law, which would include any relevant statutes for whatever jurisdiction you're practicing in, as well as case law. Best practices also are comprised of knowledge, which would be research, the research base for your practice. Also professional ethics, so the APA Ethical Principles of Psychologists and Code of Conduct, as well as the specialty guidelines for forensic psychology. And as we go forward, I'll just call them APA ethics and specialty guidelines, because those are very long names. And then professional or best practices. So professional best practices, these types of guidelines often incorporate law and ethics and research, But yeah, a lot of what we discuss coming up is comprised of all of these different things. All right, so we're going to go through a list of questions to ask prior to selecting and administering testing in a forensic evaluation. And the considerations that I'm going to go through are reiterated across the literature. So for instance, Kirk-Hilbrun has a 92 paper on the role of psychological testing in forensic assessment. There is also the Melton et al. Text psychological evaluations for the courts. So some of the language I use might look familiar because, consistent with best practices, there's a lot of things that we need to consider. So first question, what construct are you actually trying to assess? So in the context of a forensic evaluation, it can be helpful to separate out the different types of assessment tools and tests into three main categories. First, we have clinical assessment instruments. These are general clinical measures that don't really have any direct bearing on a forensic question. So these could be things like personality measures like the PAI and then PI, intelligence tests like the WAIS. And for these types of tests and measures in the therapeutic or clinical context, they might be used to facilitate assessment and diagnosis and treatment planning. But in the forensic context, they have less utility because they assess general psychological or medical constructs that don't speak directly to the psycholegal question or the referral question, like competency or child's best interests if you're doing a custody evaluation. So next we have forensically relevant instruments. So these are tools that aid in the assessment of a clinical construct that is more relevant to legally involved persons. So risk assessments like HCR20 or tests of response style like the CEUs. And then lastly, we have forensic assessment instruments. And these are tools that are specifically designed recognizing limitations of CAIs and FRIs. And these are specifically designed to assess a legally relevant construct. For example, competency-related abilities. For this presentation, most of the tests that we're talking about are going to fall into this first category of clinical assessment instruments, CAIs. So for instance, tests of intelligence, neuropsychological functioning, achievement. There's different screeners for these constructs, but the full test, these usually contain a lot of different subtests in which the individual has to answer questions or solve problems or items that have some objectively or normatively correct answer. So, 2 + 2 = 4. There's no subjective answer to that. It's objective. The performance on these types of tests is usually interpreted in light of performance norms of relevant populations or a relevant sample. The results can help determine specific strengths and weaknesses in the examinee's cognitive functioning or their academic functioning or certain areas of neuropsychological functioning. And something important here is that these tests may be used in cases where the evaluator suspects more serious cognitive impairment and needs more specific information about particular aspects of their functioning that might affect the psycholegal capacity or deficit in question. All right, so relatedly, how directly does the instrument that you are choosing assess your construct of interest? So there's no specific test that can tell us if somebody has a particular diagnosis. So we don't have a test for schizophrenia or a test for intellectual disability or MDD or personality disorder. So even in clinical assessments, we use these different tools to help aid our assessment, never to fully replace the assessment process. So using a real life example, let's say you are ordered to do a competency evaluation because attorney learns that their client recently suffered a really serious head injury. So a couple weeks back, they were in jail. Everything was, no concerns about competency. They fall off their top bunk and hit their head on the concrete floor, have to go undergo a few surgeries to repair the fractures. And then when you're seeing them, this person seems to understand what you're telling them and they understand the questions, but they're having a really hard time retaining information. So the question is, do you give an IQ test? Do you give a whole neuropsychological battery to see if there's other deficits that might be impacting their ability to learn? Do you just do a test of memory functioning like the WIMS or just the auditory subtests of the WIMS? Do you not test at all and just describe what it is that you're seeing? Like I mentioned earlier, there are vast differences in the tests that forensic examiners are using. So there's no one right answer to this question, but in efforts to enhance the reliability and usefulness of our evaluations, want to make sure that we're choosing tests that will assess the area of concern most directly and in the context of additional considerations. So our next consideration is, to what degree will the test results provide data that will inform opinions relevant to the referral question? So in other words, would the information garnered from a particular test only be peripherally relevant or a background concern to the psycholegal matter in dispute? If so, maybe rethink what test you're using. But this is one of those considerations that I can't emphasize enough. So for most types of forensic evaluations, the first question isn't, does this person have a particular diagnosis, or even do they have certain traits or characteristics or deficits? The first question is always, what is the referral question? So what question does the court or trier of fact want answered? And then from there, we build our evaluation. And, something that is also relevant here is that most psychological tests, including intelligence and cognitive tests, weren't developed or validated specifically to inform judgments about legally relevant behavior. So again, we're, they're further away from directly assessing constructs of interest. All right, and then relatedly, are there alternative techniques of assessing the construct of interest more directly? So for instance, instead of giving an IQ test to somebody who you think might have lower intellectual functioning in the context of a competency evaluation, why not use a CAST ID? Then you can compare their results to a normative sample that would be relevant and give the reader of your report or the trier of fact more specific information about the construct of interest, which really going all the way back is competency. And then again, building on some of these other questions, would using the test that you chose require an unacceptable degree of inference between the construct it assesses and the relevant psycholegal issue? So would you have to extrapolate the results or make a leap to get from these results to the question that you were actually asked by the court or attorney? So for instance, there are limitations to testing in reconstructive contexts. So if you're looking at criminal responsibility, you're trying to reconstruct somebody's functioning at the time of the offense. So of course you can do IQ testing now and say, okay, this person has an IQ of 65 now. It's likely they probably had an IQ of 65 4 months ago. But there's a lot of things that could influence test performance over time, including stress of being detained and things of that nature. So again, trying not to leap too much. Another mistake that I've seen a lot of evaluators do in evaluations is doing a whole neuropsych battery and saying, okay, the results of this testing show that they have deficits in X, Y, and Z. Therefore, they must not be competent, or therefore, whatever the question is. And that would be a mistake because there's no condition or specific deficits or even, differences in brain structure or cluster of symptoms that automatically say somebody is not competent or that they didn't know the wrongfulness of their actions at the time of the offense. So we want to be really careful about the inference we're making. So this first set of questions that we have here really have to do with relevancy and utility of testing. And this is in our ethical codes. So for instance, the APA ethical code says that assessments should be conducted with reliable and valid methods that are appropriate for the purpose of the examination. The specialty guidelines say that we must focus on legally relevant factors. So specifically, forensic examiners seek to assist the trier of fact to understand evidence or determine a fact and issue, and they provide information that is most relevant to the psycholegal issue. In reports and testimony, forensic practitioners typically provide information about the examinee's functional abilities, capacities, knowledge, and beliefs, and address their opinions and recommendations to the identified psycholegal issue. So again, really, really important to focus on relevancy. So in addition to our ethical codes and specialty guidelines that help inform our assessment procedures, the relevance and reliability of expert opinions are also established by law. So here I have the Federal Rules of Evidence, Rule 702, that regards testimony by expert witnesses. And this is mirrored in most states' rules of evidence as well. But essentially, this says that expert opinion is admissible if the knowledge that you're providing will help the trier of fact understand the evidence or determine a fact and issue. Again, relevancy, if it's based on sufficient facts or data, and if your testimony is the product of reliable principles and methods, and if you've reliably applied those principles and methods to the facts of the case. All right, and then this next set of questions also draws from our ethics and research and best practices. And the answers to a lot of these questions too will come from literature or research that has to do with psychometric properties, such as the reliability and validity of various assessment instruments. So first one we have in this set is the test commercially published and is a user's manual accessible? That's pretty straightforward. Next one, is it a reliable test? So for instance, is the reliability coefficient greater than 0.8? So when we talk about reliability, this concerns the consistency or the stability of test results. So if you were going to give the test over and over again to the same person under similar conditions, would the test produce similar results? So basically, how dependable or trustworthy or reliable is the test? Also, is the test valid? So have adequate levels of validity been demonstrated? And is it valid for the purpose in which you intend to use it? So something that I'll see sometimes is people will say, this is a reliable and valid test. Now, we might be able to say more generally, a test is reliable. But when it comes to validity, a test isn't just broadly valid. It is valid for the purpose that you're using it, because of the sample that you're using it with, or because of what you're using it for or to predict. So knowing if the test you're using is valid for the purpose you intend. Related to this is that measure generally accepted by your field for that use? And this goes along with this next point. So has the test instrument been subjected to peer review? So peer review and general acceptance are related. But the peer review process in particular is a process in which experts in the field will evaluate the quality and psychometric soundness of a particular measure. And this is usually done before it's widely published for use. And this helps maintain the integrity of the psychological assessment tools by identifying any potential flaws and suggesting improvements before it goes out for everyone to use. And then, does the instrument have a known error rate? So some level of measurement error is inherent in psychological testing. So test scores aren't ever perfect by saying this is definitely the score that this person has. They're always going to have the score. It's never going to change. So we take this into account when we're interpreting our test results, but it's also important to know a test's error rate before selecting and administering a test, because we want to make sure that error is minimized as much as possible. And this also is something that is mirrored in our ethical guidelines, these different pieces. So the specialty guidelines also indicate that we strive to use assessments that have established validity and reliability for use with members of the population assessed, and that when such validity and reliability hasn't been established, we consider and describe the strengths and limitations of our findings. Again, that comes back to the interpretation piece. And so a lot of what I talked about is also mirrored in case law. So specifically what we often refer to as the Daubert criteria, coming from the Daubert versus Merrill Dow Pharmaceuticals 1993 case. And the Daubert criteria provide a legal framework for the admissibility of expert testimony. So these are related to the federal rules of evidence that we just went over, but these more explicitly are useful in helping determine which types of tests are acceptable to use in forensic evaluations. And you'll notice we just talked about a lot of these things. So testability of the theory or technique or test that you're using to make some sort of opinion. Has this test been peer reviewed? Does it have a known or potential rate of error? And has it been generally accepted in the relevant scientific community? Also in the note of general acceptance, anecdotally and from what the research says, there isn't a general consensus on which tests we should use or which tests are generally accepted. So Neil and colleagues did a study where they surveyed forensic experts on the tests that they use and really focused on the legal standards and scientific and psychometric properties of tests, and found that 90% of assessment tools that were used in forensic evaluations had been subjected to empirical testing. However, only about 40% of these had favorable reviews of their psychometric properties and authorities like the Mental Measurements Yearbook. And then only 67% were generally accepted in the field. So it's a little bit lower than we might expect, or maybe not lower than we expect, but lower than we might want. And then something really interesting is that despite this lack of broader consensus about tests that are generally accepted in the field, attorneys really challenge assessment tool validity, and even challenges to scientifically suspect tools were virtually non-existent in this study. There's a lot of explanations for this. Some of them are things that we mentioned already, like lack of training and education surrounding tests. So for instance, attorneys should not be expected to know all of these different tests and measures. That's when they defer to experts. So, it's really important that we are being mindful of the tests that we select, given the reliance of how much the court relies on our opinions and tends to agree with them. All right, so on to our last set of considerations. First one here, do you have the competence to use this test? So what qualifications are necessary in order to use this test? This is also explicitly addressed in APA ethics and the specialty guidelines. So competency comes from a combination of your education, your training, your supervised experience, and your professional experience, as well as consultation and study. And so you might want to use a test and not have competence in it yet, but you can always gain competency in something. Can you ensure the ability to administer the test in a standardized manner in an environment that is going to be quiet and distraction-free? So this is also mentioned in the specialty guidelines under 10.04, consideration of assessment settings. We'll talk about that more in coming slides on interpretation. Something to think about before choosing your test. Does the instrument include validity indices? Now, use of the word validity here is different than the use of the word on the previous slide. So here, validity indices really means response style. So does the instrument have ways to measure if the person is being forthcoming or putting forth good effort or being candid or genuine in their responding? And again, we'll talk about response style a little bit coming up. Okay, and then how will the audience respond to inclusion of this test's results and interpretation? So we don't want to specifically choose or omit certain tests simply because of how we think the intended audience might respond to those tests. But we do still need to be mindful of how we present and interpret results of testing so that if they are truly necessary to answer the court's question or the referral question, our readers can understand that too. They're able to follow our thinking and be like, oh, this makes sense that this is included. And there's some research that shows that legal personnel like judges, lawyers, jurors might get turned around by a statistics-heavy report. So we also want to be mindful of how we're going to present the results and if there's different ways that they can be presented. So could be helpful to ask, will the reader understand what I've included? If not, what are they going to ask? Will they agree with the results or find them valid? And if not, what different pieces might they challenge? Are they going to trust what I've told them? If not, what are things that I can do to improve their trust or, fill in gaps that might be leading to them not trusting what I'm saying? And then lastly, are you including testing for reasons other than needing them to answer the specific referral question? Now, this could include a whole bunch of different things. Are you including them for training or educational purposes that your supervisee can see what you're doing or because you want to gain experience with them? Are you giving the same battery of tests to every competency examinee because you're compiling the results for research? Again, are you doing it to lend an air of science or as window dressing of sorts to, make your report appear a certain way? There's a lot of different reasons people might include testing other than to help answer the referral question. And not all of these reasons are inherently wrong, but as forensic evaluators, again, we should always be striving to conduct evaluations that are going to be helpful and defensible. But we also want to be mindful of our examinees' time and the court's time, so not doing things superfluously or if they're not necessary. So a lot of these considerations on this slide have to do with interpretation of tests. So in terms of test interpretation, basically what that means, this is the process of taking raw test data, so like quantitative results, and converting them into meaningful qualitative data. And all of these different considerations here go hand in hand. Starting with standardization, um, there's various factors that can produce error and influence test standardization. There are also times when you might not be able to interpret test results at all because the standardized administration was compromised enough. Examining characteristics like age, education, cultural background, language proficiency, those types of things could also influence whether or not you're capable of doing standardized administration. Um, if a lot of the time our folks are cuffed, and so they might not be able to do certain subtests or do them in a manner that they could if they weren't cuffed. So are we making modifications or adapting so that we can, account for that? Was there user error? So did the test administrator, the person giving the test, err in how they administered the test that, spoiled one or more subtests and therefore made the test uninterpretable? Did the examinee decide to stop doing the test halfway through? I've had that happen before. Or did an alarm start going off where everyone had to evacuate the building for 45 minutes, then you come back? Do you keep doing the test? What do you do in those instances? Because standardization has already been, kind of thrown out the window. So a lot of these things go hand in hand with testing environment. So the testing environment, like I said, the specialty guidelines make mention of this. So they say that in order to maximize the validity of assessment results, forensic practitioners strive to conduct evaluations in settings that provide adequate comfort, safety, and privacy. Various environmental factors that can impact test results include the temperature of the room, the noise levels, surrounding activity that might be distracting. So if you're like in a fishbowl and there are so all the walls are windows, are there tons of people walking by? Are there even things in your office that are distracting to individuals? So perfect example here. My office at work happens to be above the boiler room in the building. So I now have an AC unit in there that has cooled it down, but last summer I did not. And it was in the 90s, very hot. I had multiple defendants who gave responses to standardized items on tests like the WACE, where they were commenting about the heat of my office, or they were trying to rush through so they could get out more quickly. Several of them said that they really wanted to get back to the jail because it was cooler. Making comments like, I'm sorry, it's so hot. I can't think straight. I'm sorry I got snippy with you. I was just hot. I get bloody noses when I get too hot. I really hope I don't get a bloody nose. So focusing on things other than the actual evaluation. So that really could impact how I interpret those results. Also, equipment malfunctions. If you're giving any tests over an iPad or a computer, there's things that could affect how you might interpret that test. All right, then response style. So I mentioned this earlier. This is something that is particularly salient in forensic assessment compared to a clinical or therapeutic assessment because we have much higher rates, base rates of malingering or feigning. And this is arguably because there are a lot more reasons to appear a certain way. So either appear less impaired in certain areas like aggression or violence or substance use, or more impaired in certain areas like if we're assessing competency, if the person is like, no, I really don't understand what's going on, trying to appear more cognitively impaired than they truly are. So it's really important if you're giving any testing to ensure that you're explicitly assessing for response style. This could be a whole talk on its own. Again, I'll try to keep this part brief. So there's lots of different types of response style, and response style also isn't synonymous with effort, which I see sometimes in reports. People say that somebody's giving best effort or not good effort or X, Y, and Z, when really there's so many different types of response style. So like I said, somebody could be minimizing impairment, or they could be defensive or responding in a way that they think is, socially desirable, or impression management, dissimulation, feigning, malingering, exaggerating. Whole lot of different terms we can use that are more descriptive of somebody's response style than simply their effort. And even on effort, somebody could have suboptimal effort for a lot of different reasons, but they might be showing up on a test in that way, again, for lots of different reasons. But we also want to be careful of not saying suboptimal effort if their score is really low. Because if somebody's performing below chance, which would be lower than what would be expected if somebody's just merely guessing at responses on a test, if they're in that range, then they're not giving poor effort. They're actually giving really, really good effort. It's just in the opposite direction of what we would want them to do. They're working really, really hard to appear impaired. Something else on this topic of response style is that most psychological tests don't have embedded indices of like validity indices or indices that tell you about the person's effort or their response style. So sticking with cognitive and intelligence testing, best practices would say to administer these tests before you do those types of tests. So we would call these performance validity tests, PVTs. And failure of PVTs doesn't necessarily mean that the person is intentionally feigning deficits. Failure of PVTs happens in a lot of different clinical conditions. Failure of these PVTs doesn't mean that it's clinically contraindicated to give subsequent testing, but it might be depending on somebody's scores. Because if they're failing these measures, then if we were to give cognitive or intelligence testing, it might not give us an accurate gauge of that person's true abilities or their baseline functioning. So example of this, I, again, had a competency examining, and based on our interview, I suspected that she had lower intellectual functioning based on, she told me about various adaptive deficits. I also had to rephrase and simplify a lot of my questions for her to understand what it was I was asking and respond appropriately. But so I wanted to do testing to kind of elucidate some of these competency related deficits that I was seeing. But this individual also had really severe PTSD from a fairly recent event. And some of this came up in our interview the first day when I was doing background and history. So she was really emotionally dysregulated, having a really hard time composing herself. And so I had given some PVTs and she failed all of them. But I suspected it wasn't because she was trying to appear very impaired cognitively. She just wasn't able to appropriately attend to the questions on those measures, or on some of the timed tasks, she, was wiping her eyes, or just, processing speed was a little slower because she was just distracted and very, very emotionally upset. So I decided to see her a second time. Her presentation was similar. She, was thinking about some the recent trauma again, and again, emotionally dysregulated and failed those PVTs. So I chose not to do IQ testing, not because I thought she was feigning or exaggerating, but because it didn't seem like if I gave that type of testing that I would get an accurate representation of her true abilities. It would probably be an underestimate. And I didn't want to mislead the court. So yeah, a lot of different reasons you may choose to administer subsequent intelligence or cognitive testing, depending on somebody's performance on measures of response style before that. There are also some caveats to using these types of measures in individuals with intellectual disability or lower cognitive functioning. So we know that these folks oftentimes have a tendency to fake good or mask their disability. And even so, we find that these individuals are often failing PVTs. And there's a whole bunch of research on this. But some of the reason for this is because most of these measures were not standardized or validated on this population, or validated for use with lower functioning individuals. So the literature has identified alternative cut scores that can be used on these measures. And still, if somebody's scoring in that below chance range of scores, showing that they probably knew the right answer, but they were intentionally choosing wrong answers, that's when you might start to, move in the direction of, I don't think I'm going to do IQ testing. But yeah, a lot of different caveats for using these tests in this this population, just go to the research, the literature. It'll give pretty good info for you. All right, next piece here in terms of considering how to interpret tests that you might have given is the context. So context goes hand in hand with standardization and environment. So, we have to consider test results in the context of other evaluation data. So that includes other testing data. And there's a lot of manuals that specifically say that a certain score or single score shouldn't be used on its own and needs to be considered in the context of other data, or that if somebody gets a certain score on one measure, if it's just a screener, a more comprehensive assessment needs to be done. So we're never just looking at one score or one test. It's also really crucial for us to consider contextual factors. And some of these I mentioned earlier, but did the person say that they didn't sleep at all the night before? Or did they just start a new medication and they're really foggy? So what are some of these other examinee factors that could provide context for why they scored the way they did? With context, I also mean consideration and inclusion of certain statistics in your report for the reader. So like I said, a score on its own isn't particularly useful. We need to give some more context. So we should always present our test scores with confidence intervals, population or sample of comparison, percentiles, descriptive categories, etc. And this is so that the reader knows where to place this person's score. So in other words, like I said before, there's no perfect condition or perfect score. And even with perfect conditions, psychological testing is never going to be perfectly accurate because there's too many variables that could introduce error. So we can account for this using confidence intervals. So for instance, if we're using a 95% confidence interval, what that's saying is that if this test was administered 100 times, in 95 of those administrations, the examinee's true score would fall in a certain range. The percentile lets us know where that person's score falls in comparison to a reference group or a group of comparison. And then descriptive categories, these can be really helpful for our readers because it puts words to their score rather than keeping it as a number. So, something to note here is being sure that the descriptive category you're providing is accurate to what is in the manual. So I've seen some reports from other evaluators where they provide scores and they link that up with a descriptive category that isn't what's listed in the manual. It's made up. So for instance, I saw a report where I think the individual scored in the 40s and 50s on intelligence testing, and we would consider those extremely low. But they had labeled them as mild to moderate impairment, which is just not a category at all, and it also is kind of it's just inaccurate, and it made those deficits seem much less severe than they actually were. And then they used that descriptive category to provide their diagnosis of a moderate intellectual disability or mild intellectual disability. All right, so context is important. And then we also always want to qualify our results considering all of these above things. So we do this by identifying any factors that we believe based on the science and our training and experience that might have influenced the results or that the reader might need to know. So we're couching our test results in certain limitations. And so in considering all these different things that could impact test interpretation at varying levels, we need to decide if we're presenting test results at all, or how we're qualifying them. And one thing I see in a lot of reports is interpret with caution. And we don't need to throw caution out there and use that terminology necessarily, but being very specific in describing what the limitations were. And again, this is in our specialty guidelines. And the specialty guidelines indicate that, like I said earlier, we seek to describe strengths and limitations of any test results. And the specialty guidelines also mention that there are these differences between forensic and therapeutic assessments, and we may need to provide a substantially different interpretation of our test results than we would in a therapeutic context. We also have some research on bias in forensic evaluations, which I think is relevant here. So something that we want to avoid is being overconfident in our opinions or our conclusions. We always want to provide competing or alternative hypotheses, limitations, context. So certainly test results can bolster our opinions and give us some quantifiable data that we can in turn compare to research and make inferences or provide recommendations. But we also want to be mindful to not overstate what these test scores mean. So again, coming back to cognitive and intelligence testing, just like a single blood test couldn't say for sure somebody has any kind of medical condition. An IQ score isn't going to tell us if somebody is competent or not, or if they have intellectual disability. And so this leads to discussion of neurodevelopmental and neurocognitive diagnoses and when and how and if we provide these diagnoses. So a lot of considerations here. Taking it back to the basics, why do we diagnose? What is the purpose? In therapeutic contexts, it can be very, very useful. In forensic contexts, a lot of the time diagnoses aren't even required by the statute. And there's also some work that challenges the use of diagnoses in forensic mental health assessment. Again, specialty guidelines address this as well. No, it's the case that inclusion of a diagnosis might be confusing for the consumers of our reports. The DSM even cautions against use of diagnoses in forensic settings, so something to be really mindful of if you are going to give one of these diagnoses. Like I mentioned a couple times, the test score alone isn't enough. A screener also isn't enough to say somebody has a mild or major neurocognitive disorder or some sort of neurodevelopmental disorder. Usually diagnosis of these types of conditions requires a really extensive, comprehensive assessment that's outside of the context of a forensic evaluation. And I even use that language in my reports if I do suspect that somebody has one of these conditions, because I don't want to overstate what it is that I found. And also, providing a diagnosis of these conditions usually isn't relevant to the referral question. It might be, but oftentimes it's not. And so some of the exceptions to this are, if you are doing an Atkins case, so competence to be executed, we might want to do a more thorough assessment of whether or not someone has ID in that context. In personal injury cases, if somebody suffered a really severe head injury from an accident and we need to know if their current neurocognitive functioning is different from before the accident, we might do a more extensive battery of tests, but in general, want to be mindful of when we're providing these diagnoses. Okay, so putting this all together, when might testing be clinically contraindicated? So we went through all of these considerations, and in the context of that, we discussed some of the times when we might not do testing, but being a little more specific about this, don't do testing if it's not necessary to answer the referral question. I'm going to keep harping on this one because it's really important. Also, don't do testing if you already have sufficient data to inform on the construct of interest. So for instance, if you have school records showing that somebody was on testing throughout their years, they were scoring a certain way, or if you have records from your County Board of Developmental Disability saying that they are eligible for services, you have some data. You probably don't need to do your own testing. Also, don't do testing just because the person reported a history of special education or they had a TBI or some other injury to the brain, like a stroke or a seizure. Of course, these things might be relevant, but you're not doing testing just because you have that data, because the point of the assessment is to answer that referral question. And if you can answer that referral question without specifically testing for deficits that might be present, then don't do the tests. So a lot of folks report that they were in special education. Doesn't necessarily mean it was for learning problems. It might have been for behavioral problems. And a lot of folks who were in special education also report that they went on to get their GED or maybe even do some college courses. Maybe aren't showing any adaptive deficits. So they've been in the same job for 10 years, got promoted, been living independently. So we don't need to do testing. We also know that in terms of TBIs, about 40 to 60% of legally involved individuals have a history of at least one TBI. So we can't be testing 40 to 60% of our folks coming through. Usually it's not going to be relevant. So if and when these different things are relevant is dependent on a lot of factors. So specifically for different head injuries or brain injuries, you know, is might be relevant depending on the location of the injury, the severity of that injury, and how recently it occurred. There's actually a really good talk by Nicole Graham in March of 2023, I believe. She did a talk for LMH on neuropsychological testing and these different conditions. So check it out if you're interested in this more. Testing might also be clinically contraindicated if measures of response style are indicating feigning, especially if they're in that below chance performance range. Then we might not want to do testing. And then with intelligence testing in particular, there's a few instances in which we probably won't want to do this type of testing. So even if we suspect that the person is lower functioning and was before the onset of their psychiatric conditions, if they are currently experiencing active symptoms of psychosis, so they are distracted by or responding to hallucinations, or have really significant negative symptoms like thought blocking, or you see that their processing speed is really, really slowed, we probably wouldn't want to do IQ testing because it's going to produce a number that is an underestimate of their actual abilities. And we want to be mindful because a lot of the time we see that results or test results from prior evaluations are put forward in future evaluations. So we don't want to perpetuate, provide information that might not be accurate and could be perpetuated. We also don't want to do IQ testing if we see that the person recently had that same test done. So let's say you only have access to the WAIS, are only competent in administering the WAIS. If a different evaluator just did that a month or two ago, don't give it again. We also don't want to give testing to show that the person's intellectual functioning is intact. So this doesn't go for all types of cases, but if we think somebody's competent, we're not going to do IQ testing to be like, I know they're competent. This IQ testing shows that they are in the average range, therefore they must be competent. So we don't want to do that inverse. We do testing to show, to help determine if and when there are deficits that could explain why we're seeing legally related deficits. So these aren't all of them, but these are some of the big ones. All right, and then again, putting this all together, certain instances in which testing may be useful. Now, I'm not going to go through all of these. I tried to keep them specific to cognitive and intelligence testing. Went through some of these already. With competency, which is one of our big ones, we can find testing to be really helpful in determining restorability. So, for instance, if somebody is exhibiting neurocognitive impairment and is much older and we're concerned about potential dementia, then it might be helpful to do more intensive testing to help determine restorability. And we have some other examples here. They'll be available in the slides. So in sum, testing can be a really important component of a forensic evaluation, but test-intensive evaluation that occurs after little thought, at significant expense, and at the cost of other more productive assessment activities is counterproductive and can result in less accurate and helpful opinions about the psycholegal issues in dispute. So in closing, a couple of recommendations. As best as you can, select and interpret psychological testing in accordance with best practices. Again, I'm going to keep harping on this. Focus on the referral question. Don't answer any questions that you weren't asked to answer. If the attorney or the court did order or request testing, but you didn't perform it, explain why. And describe symptoms or deficits overdiagnosing when it's appropriate. So if you must diagnose, maybe do an unspecified neurodevelopmental disorder or unspecified neurocognitive disorder and explain why you're not getting more specific than that. But if you don't have to diagnose, don't diagnose. And then be mindful of the impact that our evaluations have on legal decision making. So like I mentioned earlier, there's a lot of research showing that the triers of fact really rely on our opinions, and they often don't question our methods. And so we don't want to take advantage of that. We want to ensure that we are conducting our evaluations consistent with best practices to be as helpful to the court as possible. So I believe those are all the slides I have. Here's some selected references. And then if you need the QR code for the evaluation, here that is.
Tatiana, thank you so much for that wonderful presentation. We have a ton of questions, which I just think speaks to kind of how important this topic is, and how relevant it is. So I just want to get into a few of those if we can. So one question came in asking if you would ever use a test that's not commercially available or published, with an explicit caveat in the report to that fact. So for instance, if a test was translated into another language without known psychometric properties.
Yeah, I think that's a great question. So, like we talked about, we always want to use tests that are going to, meet the Albert criteria, and tests that have been established for use in the context in which we need to use them. But if for some reason there is not a test available that you need to use, or there's certain considerations like the person's language, or we need to use an interpreter, then that's when it really comes into like test interpretation and limitations, and just document, document, document. Make sure you are couching any of those results and your interpretation in the context of potential limitations.
And there was a question about kind of the order in which you conduct testing. Do you typically conduct a clinical interview before testing? And are there scenarios in which you would do the reverse?
I think this comes back to what the referral question is. So I think we never want to do testing in a silo in forensic evaluations. And the clinical interview oftentimes can produce information that is more relevant to the psycholegal construct, or if you're doing a functional interview that provides data for that's more directly related to that referral question. I think there might be instances where it makes sense to do testing first, but I think the whole idea is that we don't want to do testing unless it's necessary. And so if we start off with testing right off the bat, we might not know whether or not it was necessary or not.
Yeah, that's an excellent point. Also, a question came in about, could a forensic evaluator just ask for a full clinical workup to be done by a clinical psych provider prior to the evaluation instead of them having to do it themselves?
I think it's possible, but again, coming back to relevancy. So the reason that a clinical provider might be doing a certain workup versus a forensic evaluator, there's a lot of differences. And so the clinical provider would be doing a full workup with probably different questions in mind. And a lot of what would be done might not be relevant or necessary to answer the question that the court asks you about. I think if if you're working in conjunction with a clinical provider or a neuropsychologist, I think it's something that you would want to, start your evaluation and determine the appropriateness or how necessary, testing is, and if it would be helpful or useful for another person to get involved and provide you that data.
And then let's just try to get to one more, because this is kind of coming up in a few different ways. In a forensic setting, we're often asked to provide an intellectual disability diagnosis, at least provisionally, in order to offer opinion not only about the defendant's competency, but also about the likelihood of restoration. However, due to limited resources and time, we're frequently unable to complete a comprehensive assessment or gather sufficient data to support an ID diagnosis confidently. In such cases, what testing do you recommend, or what alternative approaches would you suggest to support our opinions responsibly and ethically?
That's a great question. That's one that does come up a lot. So I think again, a lot of considerations here. If your statute doesn't require a diagnosis, I think it's acceptable to describe what deficits you have observed. Of course, if you think that somebody is not competent because of an intellectual disability, testing can be really helpful to show that. And I think in your report, you can explain what the test results are showing and how that speaks to the legal psycholegal question and might speak to restorability by citing the research and at what levels of different IQ scores are individuals showing more difficulty or more deficits in their restorability. Um, but I think I don't want to say any specific test is best. I do caution against screeners. Those do have utility, but use of screeners like the KBIT or the WASI might be useful in some instances, but there's definitely a lot more error and a lot more limitations to using those types of tests to determine somebody's true intellectual functioning. And then I also want to note that ID also, in our DSM, we don't diagnose ID based on an IQ score. It's the adaptive functioning that really matters. And so perhaps focusing more on that in your report and how that might speak to their psycholegal abilities. And the last point I'll make on this is the APA is currently working on establishing guidelines for diagnosing ID or IDD in forensic evaluations. And those are under review right now. If you are a psychologist and you have access to those, check them out and you can provide comments. But yeah, this is obviously a topic that's really salient and comes up a lot since we're working on those guidelines.
Yeah, absolutely. And just for people who are asking for your contact information, it is on the slide, and those will be available, as well as the reference pages. There were some questions about getting your contact information and your references. So I just want to make sure that everybody knows that. And I'm sorry that we couldn't get to more questions. There are so many questions, so many good questions about this, that I think again, just speaks to how important this topic is. And we thank you so much for highlighting some of the big considerations here. I wish we had more time to discuss it further. But that wraps up this week's Law and Mental Health series. Next week, Christina Dardis will join us to discuss technology-facilitated intimate partner violence. We hope to see you then for another great discussion of issues of forensic behavioral health and the law. And until next time.
Thank you.
Bye.